Hi, welcome to the 7th episode of Orthodontic Matters. I got a few questions about crossbite cases, and we have an example here with what's called unilateral crossbite. Actually, oftentimes, or in most of the cases, when you see a unilateral crossbite, it's usually constricted upper arch with where an occlusion, the patient develops a functional shift or force bite, and it appears to be a unilateral crossbite, but actually it's more like a bilateral crossbite with a functional shift that appears to be on one side of the unilateral crossbite now. And usually these are more mild constrictions, about 5-6 millimeters, what I usually see with a unilateral crossbite. Some of you asked how do we treat these cases. To be honest, what we have the best luck with is what works really well is an acrylic splint expander for a lot of reasons. One, to really see where the crossbite is coming from, we have to eliminate the functional shift of the force bite, and acrylic splint is great at that. So what you'll see is you put the acrylic expander in and eliminate the occlusal interferences, and oftentimes you see the true crossbite as it is without the functional shift. So you see a lot of times as a result from the functional shift, the midlines are aligning up, but after the patient wears the acrylic expander and it works as a deprogrammer, oftentimes the midlines will line up very nicely, and then you can see the bilateral crossbite at that point. Now, if the patient's a little bit older, like in the case that we're going to show you here in a second, that patient was actually 21 years old. After she wore the acrylic expander also as a deprogrammer, her midline aligned almost perfect, about 1 millimeter off, but not perfect. Because her functional shift became more permanent by that age. Nevertheless, we were able to do an expansion, a suture expansion, actually on a 21-year-old with acrylic expander. Is quite common. It's been published in several of the orthodontic literatures, and that's something done commonly, but we do it quite successfully. Like in these cases, you can see we get no dental tipping, and we get nice suture expansion, and she was 21 years old. So you can see in this case that if you measure the upper arch in model analysis, the upper arch from mesiobuccal cusp or mesiobuccal cusp is 41.8 millimeters, about 42 millimeters. But if you measure the lower arch, it's 47.3 millimeters. So on the buccal groove of the lower sixes, so there's about a 5 millimeter crossbite, and you can see it as a unilateral crossbite on the right side, as you can see it on these pictures. So what should we do now? As I said, the best would be is to use an acrylic expander that's going to cover the sixes, the fours, and the fives on the upper arch. We usually put a tube at the 4 position in the acrylic, so we can run a wire for the anterior teeth. So while we're doing the expansion, you can also align the front teeth, and if usually there's a space develops between the upper ones from the suture expansion, so we can close that space while we're, after the expansion is done, and we're just waiting to remove the expander. Usually wait about 2 months before we remove the expander. So best is to really put the acrylic expander on, do the deprogramming, see if the midline will align really nicely, and then see if the model analysis was correct and determine the exact expansion that needed from the model analysis and confirm it from what you see clinically. And we usually keep the expander on for about 2 months after expansion is done. We tie off the screw, and then we remove the expander a couple months after the expansion is complete. In our patients in this example, we expanded 7 millimeters. 5 millimeters was the needed expansion, and we did 2 millimeters overcorrection. And as you can see from the finish case, there is really no tipping of the upper teeth, and the lower arch nicely uprighted, and we get nice class 1 result. And the midline almost perfectly aligns up. Now she was older, so it's sometimes with older patients you see that the functional shift becomes more permanent because the patients can actually get a differential jaw growth. One side can grow more than the other, and this functional shift become a permanent asymmetrical arch growth. So that's fairly common in patients who are older than 14. And one more thing, usually it's best, a lot of times with these constricted upper arch cases, the lower teeth are tipped in lingually, so usually it's best not to put like an appliance on the lower, because as you expand the upper from the pressure of the tongue, the lower teeth will upright. For example, in younger kids, it's best not to put the lower lingual arch on if you're planning on using a lower lingual arch, because as you upright the upper, as you expand the upper arch, the lower teeth will upright from the tongue pressure, and we get lots of examples for that. If you have any questions, welcome to send us a note or send us a comment or an email. Hope you found this video helpful, and as I said, I would highly encourage you when you see these crossbite cases to do your model analysis correctly and make sure you determine how much crossbite you're really looking at. If you think you have a functional shift, as you oftentimes you do with when you see a unilateral crossbite, make sure you use like a deprogrammer so you can eliminate the functional shift and you can truly see what the crossbite is. I would encourage you to stay away from expanders. Sometimes I see doctors use these expanders that only pushes on one side and one side versus the other. If you take a frontal ceph, a lot of times you can see that the upper arch is symmetrical in these unilateral crossbite cases. The problem is the lower arch and the functional shift. So now if you put in an expander that expands on one side more than the other, you do this asymmetry. What you're doing is you're starting to match the upper arch to the lower arch that's actually at fault. So now you're fixing what's right and not fixing what's wrong. So usually the best thing is to do the deprogramming, make sure you eliminate the functional shift, and then you could take a frontal ceph and you can see how symmetrical most of these upper arches are. And as I said, the lower arch of a functional shift creates the unilateral crossbite in many of these cases. So I hope that makes sense and you found this video helpful. Just send us a message. Don't forget we have a webinar on the second Saturday of the month at 9 a.m. Eastern Standard Time. If you're interested, $50 the tuition, and it's a 1 CE credit for the orthodontic webinar, second Saturday of the month. And send us a note, and hope to see you at some of our seminars. And thank you for listening, and have a great day. Bye.